chronic pain management and primary care. We're privileged to spend time with two members of the team today. Katie Osterhage, practice facilitator and research scientist with the University of Washington, and Dr. Michael Parchman, who I will introduce in a moment. Please be watching for an email following this event and a Zoom link for office hours next week on Thursday, April 8th at 1 p.m. Pacific Standard Time with Katie and Michael for a follow-up discussion, whatever you'd like to talk about, questions, best practices, things that spark your interest during the presentation today. Comagine Health, our mission is together with partners, we work to improve health and create a better healthcare system so that people and communities will flourish. Our opioid work is focused on promoting safe prescribing practices, decreasing opioid use, and improving behavioral health outcomes. A couple of housekeeping items in a moment. Please turn off your cameras and mute your microphones. You are welcome to chat with us anytime during the event. For logistical reasons or with questions, we will be tracking questions you may have for the office hours and if we have a few moments at the end of our presentation. And let us know you're here. Put your name in the chat with your organization. We will be recording this event and it will be uploaded to comagine.org so that you can review it or share it with others. I'm honored to introduce Dr. Michael Parchman, Senior Investigator with Kaiser Permanente Washington Health Research Institute. What strikes me most about you, Dr. Parchman, and your team is your commitment to this work and your ability to build relationships and to share insight and teaching whenever possible. Thank you for that. And welcome, Dr. Parchman.
Thank you. It's really great to be here. And I'm also really privileged and happy that Katie Osterhage is able to join us. She has been a great partner and team member for this project for the past several years in the 6 Building Blocks program, and I'm glad she's here. I also would encourage you to just enter questions in the chat as we go, and we'll try to monitor that. So let me share my screen, make sure you can see that. Maria or somebody, can you see my screen?
Looks like we can see it, but it's not quite in presentation mode yet, Michael.
Getting warm.
I can see the blue circle. Maybe it's thinking about it.
Okay, well, let me know when you can see the presentation mode. No?
I think if you go down to the bottom of your screen and click that little book looking thing that's right beside your, yes, reading. There you go.
Perfect.
Great. Well, thank you so much. So the purpose of today is just to give you an introduction to this program, tell you sort of the story behind the program, and then discuss a little bit more areas in which the program has been used. So this is the team that has been supporting this program for the last several years. In addition to myself and Katie, you can see Dr. Larme Baldwin, Brooke Ike, and Ashley Johnson, all of whom are at the University of Washington. So I also just want to acknowledge that Maria, who's on the call today, has also been participating in supporting other organizations with this program as well. And we're really glad that she's been able to join us. So why are we talking about primary care, and why are we talking about opioid prescribing in primary care? This chart or this graph is an illustration of where most opioid prescriptions that come out of your local pharmacies originate by volume. So this is total claims, total number of pharmacy claims broken down by specialty. And as you'll see, right at the top of the list are primary care providers. So the vast volume of opioids that are coming out of our pharmacies, those prescriptions originate in a primary care setting. And the point is that we're not going to be able to address this opioid issue if we're not going to the source of where the opioids are coming from. And although we've seen a decline over the last several years in the volume of opioids coming out of our pharmacies, starting around 2011, we are still, if you look at that line on 2019, 2020, we still are prescribing twice the volume of opioids than we were before this epidemic started back in 1998 or 99, when people became aware of this issue. So we're still not there yet. We've got some room to improve. This may be familiar to some of you. This is the risk of overdose based on the dose of the opioids. Those are usually calculated as what we call a morphine equivalent dose. So that's the MED you see on this graph. And what you see is the relative risk, which are the numbers on the left-hand side, based on the dose prescribed. So if you're on less than 20 MED, your relative risk is very low. 20 to 50, you have a 44% increase in your risk of an overdose. But if you're on 50 to 100, you have a 373% increase in the risk of having an overdose. And it's an exponential increase up the graph. This data has been validated in numerous studies since 2010. It's not a one-off. Everybody who's looked at this data comes up with this same curve, same exponential curve. We know that 130 Americans still, and this data is a little bit old. We know that during the pandemic, these numbers are worse. I haven't seen the recent number from this last year. I think they're still crunching the data, but we know that it's higher this last year than it was before. I want to go back and just make the point that it's not just the prescription opioids coming out of the pharmacy that are going into the hands of the person to whom it is prescribed. It is also the diversion of those medications out into the community, whether intentional or even unintentional, where there are pill bottles sitting in medicine cabinets that disappear, and they go out on the streets. And the reason that's important is because the CDC has documented very well that 3 out of 4 people who are currently heroin users started with prescription opioids. So prescription opioids are a source of problem not only for people who are using them daily to control their chronic pain, but they're also a problem in that they end up out on the street and they end up leading, and they're a pathway to illicit heroin use and illicit fentanyl use as well. Okay, so let me tell you about the background behind our program, the 6 building blocks. Where did it come from? It was actually serendipity. We were involved in a project several years back with the Robert Johnson Foundation, and they asked us to visit and find out how are primary care teams that are high functioning doing their work. How do you create a really high functioning team in primary care? So that was the overarching objective. We identified 30 sites across the country that we thought were doing well with really high functioning teams. We went and spent a week in each of their practices to learn about what they were doing. And after about the 3rd or 4th visit, we began recognizing that all of them had been addressing opioid prescribing, and all of them had a similar journey or a similar path to addressing opioid prescribing in their clinic. So we began paying more attention and deliberately collecting data about that. And we ended up finding that about 20 of the 30 sites we visited had really intentionally addressed opioid prescribing and done it in a very similar fashion. And we distilled those learnings about what we learned from those sites into what we call the 6 building blocks. So all of these 20 out of 30 sites had been doing work in all 6 of these areas, developing consensus about this is a priority. We need to work on this. Leadership support, working on clinic policies, revising workflows, updating patient agreements, tracking and monitoring these patients as a subpopulation to make sure they're not falling between the cracks and aren't being cared for in a way that identifies risks. Making visits planned and patient-centered. These patients have chronic pain, working with them in a shared decision-making way to care for their pain, and identifying resources for more complex patients, because some of them are challenging to manage. And then finally, just developing ways to monitor the work you're doing and saying, are we successful at redesigning our clinic? And is everyone on the team involved in this effort? Because it really is a team-based effort in these clinics. Everyone has a role to play, from the front desk to the back office, to the nurse care manager, to the medical assistants, to the prescribers. Everybody has a role to play in making this work. So we rolled this out and we did a study of it in 20 rural serving clinics in Eastern Washington and Central Idaho. You can kind of see here some of the support we provided them and the pathway we took to supporting them, kind of the stages they went through. It took them about a year to really kind of get things in place and feel like they were doing the right thing. And what we found over that time period, over that 12 to 15 months, was that there was a steady decline in both the number of patients who were on daily opioids long-term for their chronic pain, and a decline in the proportion of patients who were on opioids and the number who were on higher dose opioids. And if you go to this link, I think we're going to post it in the chat for you. You can actually go to the original study and look at the publication with the statistical analyses about this. What was really satisfying to me, though, was we saw really improved work life for those who are working in these clinics. It increased their comfort and confidence in caring for these patients. They reported their stress levels were down, and they actually reported that the relationships with these patients improved, which was surprising to many of them, because they were really expecting pushback from patients when they began implementing these changes in their clinics about new policies, new patient agreements, having conversations with patients about their risks. They were just really surprised at how little pushback they got and how satisfying it was in doing this work. So we began working on spreading this program. We have support from the State Department of Health through their CDC grant to address the opioid epidemic, to support practices across Washington State. We developed a self-service guide that's on our website, and you can go to our website, the improvingopioidcare.org website, to find out more about this and download the self-service guide. We've trained people who do QI in their organization about the program and how to implement the program. We've been doing national webinars about how to do this work in other states. And we're currently hosting a learning collaborative on taking it the next step, which is the medication for opioid use disorder program and how to do one that's integrated into the primary care setting. And that's really fun. We're really having fun with that. The program's been adopted nationally. Oregon has a version of the program that they're doing. It's been incorporated into the implementation package for the CDC's chronic pain guidelines. SAMHSA includes it as an evidence-based practice resource. And the BRE Collaborative, the 2018 Collaborative Report and Recommendations, includes the program as a resource. So again, I would encourage you to go to the website, improvingopioidcare.org, and just explore it and look at the resources that are there. I especially encourage you to look at the clinic resources. So if you just go to helpful resources and look under clinic resources, you'll find resources for clinics, such as model policies, tapering guidelines, tips for having difficult conversations, tips for how to risk stratify patients, tips for how to track these patients. Where do you find them in your data and your EHR? A lot of helpful resources, including a COVID-19 handout about how to do chronic pain care virtually and opioid prescribing. So I'll pass the baton back to Maria.
Thank you so much. I wanted to just field any questions that are out there. And I know Lisa Ray Thomas, you're on the call as well. We were mentioning before we started that it'd be great to get some personal experiences of working with the material. I was trained as a practice facilitator and worked with 2 hospitals in this region. And I found that through the pandemic, it was especially challenging, but still engaging. We shifted to virtual work and stayed engaged. 6 months longer than we had planned, but I found it very effective, user-friendly, especially having to switch to remote. I had the advantage of having some months in the building with the improvement team. But Lisa Ray, I don't know if you want to share your experience, and I think if anybody else is on the call, please chime in.
Hi, Dr. Parchman. Hi, Katie. Great to see you again. And thank you, Maria. So when I was with the Olympic Community of Health, gosh, we started working with you back in 2018, I think.
That's about right.
Yeah, the region decided that addressing opioid prescribing for pain was super important as one of their strategies. And I had the privilege of working with the team, lots of road trips out to the peninsula, meeting with the different providers. And what I and the teams at the providers really appreciated was how compassionate and innovative the work is, as well as adaptable and flexible, because each of our organizations was at a different place in terms of policies and procedures and prescribers, and your team worked really hard to meet them where they're at and move them the way they wanted to. So I miss working with you. It's great to see you. Thank you.
Thank you, Lisa Ray. Yeah, I think that's all part of the fun is everybody's at a different point in the journey on addressing opioid prescribing in their primary care setting and figuring out where they are and what they need, what their needs are right now, what their priorities are right now. The program is very flexible and very adaptable to meeting them where they're at.
I see my colleague, Amy Etzel from the BRE Collaborative. Do you want to talk at all about your experience being a practice facilitator?
Hi, everyone. Hello. I also went through the 6 building block practice transformation training. Unfortunately, I went through it during COVID, and so none of the clinics that I currently serve as a practice transformation coach have engaged yet. It is something that they, one clinic in particular had engaged the Kitsap Medical Association. They had already started working with 6 building blocks prior to COVID, and then they are working with me through another BRE initiative. And so we're wrapping our 6 building block work into the action plan clinic. And I actually have a meeting with her directly after this. And it's just such a user-friendly, evidence-based approach to this work, and really helps highlight why it's so important, and gives really concrete, applicable, tangible action steps for clinics to take when clinics are feeling overwhelmed or lost. This is a really good roadmap for them.
I also found that from a quality improvement point of view, it gets people from disparate parts of a site possibly in the same room talking. If there are, I know there was one hospital where one clinic had really pretty good prescribing practices, another not so much, and they started sharing with each other, and the relationships were built because they had time to build them and to talk about uncomfortable things, as well as sharing strategies with each other. So that's the other really the strength of the curriculum, is it is through the lens of a quality improvement process. So we have, it looks like we're at time. Is there any other comments or questions out there?
I just want to add in my new, well, not new anymore, my role with the ADI, I'm really excited to see you folding in MOUD as a part of this, work, because as providers change their prescribing practices, they're going to identify people with opioid use disorder. And so how to best treat them in the most compassionate, accessible way is so exciting. So thank you for that.
Yeah, we believe that this program is a entry ramp into getting people interested in treating OUD. Because once they're comfortable with their opioid prescribing and have addressed it, they start saying, oh yeah, we have patients that we didn't recognize before, and oh, they won't go anywhere else. They're only going to come see us, so we better take care of them.
Well, thank you so much, everyone. Be expecting an email with an invite to an office hour next week for a 1-hour discussion. That's April 8th at 1 p.m. Pacific Standard Time. And we just are grateful again, Dr. Parchman, Katie, for your time and all your work. Thank you so much, and hope you all have a good rest of your day.
Bye, everybody.